Okay. All right. Well, good afternoon, everybody, and thank you for joining after a busy day at work. It's always really appreciated when doctors take time out of very busy days, especially at the end of the day. So I'm glad you're here. We'll only be an hour, and I hope it's going to be a very valuable hour for you. As Joe mentioned, I'm going to be speaking about scar treatment using Tixel, which has been coined a novel thermomechanical skin resurfacing technology. And I'll get into more detail about that actual term in a minute. But I'm also going to be looking at transdermal drug delivery with Tixel. Tixel is used for many different things. So scars are just one of many different indications. So just bear that in mind while I'm giving my talk, that if this technology can help scars, imagine how it can help other skin conditions. So my disclosures, just that I train for GenOp, Tioxane, and Tixel. So what is thermomechanical ablative technology, or TMA as it's termed, or Tixel as we fondly know it? Basically, TMA is fractionated pure thermal energy combined with motion. What's interesting about TMA is it's a non-laser, non-radio frequency, non-ultrasound energy-based device. It doesn't involve needles or breaking of the skin surface with needles either. And that's why it is a completely new concept. And if you have a look at this picture, you'll see the little titanium-tipped pyramid-shaped cones, and those press onto the skin without puncturing the skin, and without any of the complications that can occur with laser and other treatment modalities. So the thermal energy, pure thermal energy, is emitted through these cones. And the Tixel head is a matrix of 81 cones, and they're in a row of 9 by 9. And that's in an area of 1 centimeter squared. So this gives you 81 little dots on the skin created from that thermal injury. There's also an ophthalmic head, which has 24 little titanium cones. It's smaller, in a row of 6 by 4. And I use that a lot for scars as well, especially for small, difficult areas to reach. So the cones are heated to a temperature of 400 degrees Celsius. That's quite significant. That's quite significant heat. It's actually similar to the temperature that's generated by a CO2 laser beam, but without the complications and downtime associated with CO2 lasers. Because it heats to 400 degrees Celsius, the cones are auto-sterilizing, although most of us with Tixel still clean the Tixel head between patients. So ablation occurs through a very quick contact in milliseconds of that preheated tip directly onto the skin surface. So if you have a look at the cones, you'll see that they're blunt and they don't protrude the skin, as I mentioned. So the technique is a non-invasive method of heat transfer of pure thermal energy to the tissues through contact. And when I originally mentioned that it's a combination of thermal energy and motion, the motion is the pressing of the cones onto the skin. And that can be adjusted according to the skin type and the indication as to how far we will press into the skin. So the penetration depth and the pulse duration are adjustable. So we can actually make this a treatment that is ablative and non-ablative, depending on our settings. We also change the settings according to the patient's skin, if it's Patrick's skin type, and according to the indication. For example, I'm going to use a much lower setting with a much quicker pulse duration in a patient around the eye area compared to the neck. The TMA has really revolutionized the field of fractional devices, especially in darker skin types, because what's amazing about Tixel is that it doesn't require the presence of humidity and it doesn't require chromophores to work. And it doesn't cause that explosive ablation or coagulative necrosis or charring that you get with other treatment modalities. Now, this talk is about scars, so let's get back to scars. I have quite a lot of studies that I'm going to share with you tonight. And this study by Chavit et al. Shows that TMA has very promising results in scar treatments through 3 different treatment modalities. The one is skin ablation, the other is bioremodeling, and the third is transdermal drug delivery. So those people who know about scars and treat scars will know that we need to have an ablative treatment for scar treatments to be effective. We need to break down the abnormal type 3 collagen. We need to bioremodel and build type 1 collagen. And it's really important to get certain medications into that scar, specifically keloid scars and hypertrophic scars. So transdermal drug delivery is very important in treating scars. Transdermal drug delivery, just a little bit of revision for those of you who haven't heard about it or haven't studied it for a while. It's a well-established method, an alternative method of getting drugs into the body instead of using the parenteral or the oral route. And in medicine, over the years, different techniques have been used to perforate or puncture the stratum corneum to increase the uptake of topical drugs. And in the past, they've used electroporation, ontophoresis, lasers, microneedling, that's a very common one, radiofrequency, microneedling with radiofrequency, ultrasound, plasma exoresis, and sonophoresis. But the most significant challenge in achieving efficient transdermal drug delivery is creating a passage through the stratum corneum that doesn't cause a hectic amount of damage to the viable epidermis and dermis. So the current methods actually cause damage to the tissues, and that actually hinders the efficacy of transdermal drug delivery, and it actually reduces the passage of drugs to the target cells. So, for example, with laser, there is coagulative necrosis and carbonization that happens after a fractional laser. And that actually causes a physical blockage to the pores that are created by the laser. And in the case of microneedling, there is an inflammatory healing process and clotting that occurs, and that actually causes a mechanical blockage affecting the transdermal drug delivery. But what we want ideally with transdermal drug delivery is a balance between effective delivery, homogeneous distribution, safety to the skin, minimal pain, low cost, and rapid healing. And Tixel is able to provide all of those. So the reason for this is that TMA creates micropores through fractional elimination of stratum corneum. So that extreme heat that's applied to stratum corneum, it makes a pore in the stratum corneum, and then it desiccates the superficial epidermis, and then causes quite severe dehydration in the dermis. So that creates void spaces and a very spongy, dehydrated dermis. And this creates a water concentration gradient. And if you can remember from medical school, Fick's law of diffusion, this allows hydrophilic material to flow inwards. So we're not creating a lot of damage to the tissues, and yet we're creating a very efficient concentration gradient to allow absorption of topical products. And I think of Tixel as it creates a sponge in the skin. So the little titanium tip creates tiny microchannels, 170 micrometers wide and 1,250 micrometers apart. And this creates very discrete and uniform treatment zones. The channels stay open for 6 to 12 hours, and that allows for penetration of active products. So this afternoon, I actually just treated a scar from a melanoma removal, and I have applied cling wrap to the patient's scar, and she's gone home with that on for the next 6 hours. So our examples of topical products that we use in aesthetic medicine after Tixel include hyaluronic acid, vitamins, antioxidants, those speak for themselves, also peptides, tranexamic acid, botulinum toxin, especially, for example, an itchy keloid scar, a 5-fluorouracil, alpha-aminoalinic acid, hydroquinone, tretinoin, and cortisone. So the list is large. There's more than that, but those are the common ones that we use with Tixel with great results. Just having a look at the type of scars that we find challenging in our practice. So obviously keloid and hypertrophic scars are a very troubling complication of wound healing. And they develop after trauma, after surgery, acne, burns, body piercings, and they have a predilection for younger patients and patients with a higher Fitzpatrick skin type. keloid and hypertrophic scars also have an associated family history often. Traditionally, we used intralesional triamcinolone acetonide, which is a type of cortisone, and 5-fluorouracil, which is a type of chemo drug. These would be injected into the keloid and hypertrophic lesions. This is our first-line treatment. There are many different treatment modalities for keloid scars, and these include surgical excision, cryotherapy with liquid nitrogen, silicone-based compression dressings and other compression therapies, radiation, and laser, all with varying results. More recently, laser has been used as a means of transdermal drug delivery to overcome some of the problems associated with these intralesional injections. But laser is painful and costly, and there are, unfortunately, a high risk of adverse effects, especially in patients with darker skin types. And some of the challenges that we face in treating keloids and hypertrophic scars are a very high recurrence rate, often unsatisfactory results. The intralesional injections can actually cause epidermal, dermal, or subcutaneous atrophy, hypopigmentation, and quite severe hyperpigmentation, and telangiectasia. The other thing is it's quite difficult to get an even distribution of product in these lumpy, irregular scars. And as we all know, it's a very painful procedure, which is a significant drawback, especially in pediatric patients. So there's a study that's come up that's worth reading. It's by Artsy et al., entitled A New Approach in the Treatment of Pediatric Hypertrophic Burn Scars, Tixel-Associated Topical Triamcinolone and 5-fluorouracil delivery. And this study actually demonstrates that thermomechanical drug delivery using Tixel of triamcinolone and 5-FU is safe, it's effective, and a promising option for the treatment of keloid scars, particularly in pediatrics. In this case, immediately after the treatment with Tixel, they applied triamcinolone and 5-FU topically in a ratio of 1:9, and then they applied occlusion. They did 8 treatments in 2 to 3 weeks apart. The study showed a significant improvement. If you can have a look at this, the child that they were treating, a significant improvement in toughness of the skin, in thickness of the scar, the color, the general aesthetic impression of scarring. But what's most interesting is that there was no need for any sedation or physical restraint. There was no need for a general anesthetic. The patient just had topical lidocaine applied. And with a treatment like this in a child where it's widespread, and often burn scars are very widespread, Tixel is a really nice alternative to laser. Another study by Amnon et al., entitled A Novel Thermomechanical System, Enhanced Transdermal Delivery of Hydrophilic Active Agents by Fractional Ablation, tested 3 different substances to check the efficacy of the transdermal drug delivery with TMA. So they chose 3 hydrophilic substances, verapamil, diclofenac sodium, and magnesium ascorbate phosphate. And the results showed no significant collateral damage to the skin tissue and no necrosis or dermal coagulation. And the skin permeability of hydrophilic molecules, which normally poorly penetrate the lipophilic stratum corneum, was significantly enhanced using TMA as a pre-treatment. Another benefit of Tixel and TMA technology is the reduced pain. Now, treating scars can be a very painful and traumatic experience. The patient I had this afternoon was in tears when she was telling me about her scar. So there's a lot of trauma associated with scars, and the patients are often quite fearful and vulnerable. And then to still have a painful scar treatment is actually almost too much to bear. But when it comes to Tixel, the pain is much less. And the reason is that there are 2 types of pain receptors in the skin, nociceptors. The first are the A delta fibers, and they're known as the fast pain fibers. For example, if you prick your finger with the needle. That will stimulate the A delta fibers. And then there are the C fibers, which are the slow pain fibers. And that's the pain that you'll feel, for example, after a sunburn. And if you compare laser to Tixel, you'll actually find that laser applies very short pulses in microseconds. And the laser light is then absorbed by water, resulting in very high temperatures within the tissues. And this activates the A delta fibers, causing acute pain. But with TMA, the pulses are actually in milliseconds. And the heat is absorbed slowly by water molecules, and slowly being a relevant term here, and vaporizes more gradually. And so it's the C fibers that are activated with Tixel. So the pain is delayed. So the actual shot of Tixel is not too bad at all. And then afterwards, they say it feels like sunburn, which, you know, is much more manageable. This particular study by Artsy et al., it's called the Scar Bane Without the Pain, a new approach in the treatment of elevated scars. Also really worthwhile reading that. And if you want any of these articles, Joe can get them to you. But there's more to pain with Tixel. The other thing is that pain fibers are located in the deeper epidermis at a depth of about 50 micrometers. And so pain levels with TMA are relatively low compared to ablative laser because the temperatures reach a much deeper layer. The temperatures at the deeper layers are much higher with radiofrequency and laser compared to TMA. And pain receptors are very sensitive to temperature change over time. So with CO2 laser, with it heating up to 400 degrees in 200 nanoseconds, is a significantly faster, a faster rate of change compared to TMA, where the heating is much slower. So basically, just a summary about the pain is that C fibers are activated by Tixel as opposed to the A delta fibers. And the other difference is the temperature change over time is much slower. And the depth is also much shallower. So after speaking about transdermal drug delivery and after speaking about the pain with Tixel and the actual technology behind Tixel, I'd like to share with you some personal case studies that I have done over the last few years. Joe, is there anything you want to say before we go into case studies? Joe? Well, I will continue then.
All good, sorry.
All right. Anything you wanted to say before we move on to case studies?
No, I think you've really actually covered how efficient Tixel can be for various things, especially the drug delivery as well. Okay,
thanks, Joe. All right, so this patient is a 52-year-old female who got she had a mole removed behind her ear and she developed an itchy keloid scar. And I treated it with 3 sessions of Tixel. I infused it with botulinum toxin. So this is topical botulinum toxin applied after the Tixel together with some 5-FU and TAC. I use a ratio of 1:9, exactly as we do when we inject keloids. So I applied the solution onto the skin, rubbed it in, and applied a plaster to occlude. These 2 treatments were done a month apart, and the 3 treatments were done a month apart, and the setting was 12-1000. What that means is that it was the heat was applied for 12 milliseconds, and the depth of the penetration of the cones was 1 millimeter, or 1,000 micrometers. I want to show you an in-between picture with this patient. So this is after 2 Tixels. I don't know, can you see my arrow? Joe, can you see the arrow?
Yes, all good, we can see it.
This is after the second Tixel, and it's almost like we returned this lumpy keloid scar back to the original scar that she had after her mole was removed. And then after a 3rd Tixel, a very nice ironing out of the scar, and just really lovely result there. And the itchiness disappeared totally, so that was also great. If I remember correctly, I think I applied 5 units of Botox. This patient was a 23-year-old male, an Indian patient. This keloid was actually, his keloids were multiple all over his body. And because of cost, we alternated Tixel and Dermapen. So he had Dermapen microneedling and he had Tixel alternating. Each time, whether it was with Dermapen or Tixel, we infused with 5-FU and triamcinolone. The setting was 10-800, and he applied occlusion for 6 hours. And just to close, when I did Dermapen for him, I also injected the 5-FU and TAC. So we managed to flatten the scar quite significantly without any surgery, without any cryosurgery. But this patient is going to need ongoing follow-up. This patient is a 64-year-old female who had a basal cell carcinoma excised, and this is after 2 Tixel treatments. Here I infused simple mesotherapy scar solutions, Centella asiatica and organic silicone. The setting was 12-1000, and the treatment was 6 weeks apart. So she's subsequently is doing more treatments, and she's going to get an even better result. This is a 65-year-old patient who has a scar from a fall. She was also in tears because it was right in the middle of her face. There was no way to hide it. And she had 3 sessions of Tixel. Again, I just used organic silicone and Centella asiatica. The setting also was 12-1000, and the treatments were a month apart. And you can almost not see the scar at all. This is myself, actually. I was born with a giant melanocytic nevus on my forehead, and I had a skin graft 3 years ago, and this is after the skin graft. After 3 Tixel treatments, you can see that the skin graft has healed really nicely and blended very well with the old skin graft. My therapist infused AQ recovery serum, as well as organic silicone and Centella asiatica. And the setting was 12-800, and the treatments were a month apart. This patient had quite a nasty scar after a brow lift, and I think it was the tension that was on this scar that caused it to become wide like this. She was understandably upset after having a facelift that the scar was so visible on her forehead, and she wasn't the type of person to have a fringe. So we actually gave her 7 sessions of Tixel. We actually just infused hyaluronic acid, and she got beautiful results. I also treated her hairline with hair filler just to try and get her hair growing better to hide the scars. And if you look from the side, you can hardly see her scars today, and she's feeling a lot better. This patient has interesting hyper and hypopigmented scars from acne. This is a tricky condition to treat because it's a mixture of hyper and hypopigmentation. So what we did was we used Tixel and we infused tranexamic acid and glutathione into the tissues, and we did 3 sessions, and I alternated it with 3 Dermapens. So in total, she had 3 Tixels and 3 Dermapens, and the setting was 12-1000, and these are her results. And what I love about this particular result is that everything has been normalized here. So we've normalized her melanocyte function. We've normalized her keratinocyte function. We've basically just restored her skin to normal. And I think a lot of the time with treating scars, that's all we're really trying to do. We're trying to get rid of the type 3 collagen. We're trying to improve angiogenesis. We're trying to improve lymph drainage, and we're trying to build type 1 collagen and to reduce pigment that's often associated with scars. This is the same patient, just from 2 different angles. Her skin is just so much healthier, and the hypopigmented areas are actually producing melanin, which looks like she's got makeup on, but I can promise you she was not wearing any makeup. This is an interesting case, a 60-year-old female who had a vascular occlusion. And these photos are taken on week 2, 3, 4, and 5. And because of occlusion of the zygomaticofacial artery here, she got a necrosis. So this is not just an ordinary scar like my patient that had the fall. This is a necrotic scar. This is a necrotic wound, and it's challenging to treat. And it was associated with a massive amount of trauma as well. So she was traumatized. She was very, very anxious. And the worst part is that if you know your anatomy, zygomatic artery is actually a cutaneous branch of the ophthalmic. And if that filler had got into if it had traveled from her zygomatic artery retrograde, it would have entered in the lacrimal artery, then it would have entered into the ophthalmic. So she was actually very lucky that she ended up without any ocular complications. The other complication she had was not only the scar, but she also had malar edema after her vascular occlusion. So if you can see here, she was left with quite a lot of sort of a festooned malar edema in this area. And that scar we treated with Tixel. We did 5 Tixels. First of all, because it's not particularly painful, with a little bit of lidocaine, it was painless. It's not much downtime with Tixel, literally 4 or 5 days max. It wasn't painful for her, and she was a traumatized patient. So it was a very nice treatment to be able to offer her. She also had some dermapens as well, but that's something that she does anyway, as she is a patient who enjoys dermapen. And these are her results from Tixel. And you can see that you actually have to really look hard to see where that occlusion was, where that necrosis was. And if you have a look, it's also, the Tixel has also improved her malar edema because it's firmed and strengthened the skin through the collagen induction. This is a 28-year-old patient who had a dysplastic nevus removed. And yeah, she was quite distressed. I mean, she was about to get married and she had this scar on the side of her face. But after 2 Tixels at a setting of 12,000, she actually could hardly see her scar with a tiny bit of makeup on her wedding day. Couldn't see anything at all. I think the secret here was using AQ serum. AQ recovery serum is human growth factors. A really, really effective, but unfortunately quite expensive serum. This patient is one of Joe's patients. She has a nasty shingles scar on her forehead, 23-year-old patient with hyperpigmentation. So she's only had 2 sessions of Tixel, and with her dark skin, you can see her setting was a non-ablative setting, only 6,500. I mean, that's half of what I've been doing. A month apart, infused with triamcinolone acetonide, and with using neotone radiance and neotone serum for home care. And I mean, after 2 Tixels, this is quite a significant improvement. So I'm looking forward to seeing how this patient will be after another 4 Tixels. This patient is the photograph is courtesy of Dr. Park. It's an acne patient. So as you can see, it's an active acne as well as acne scars, and you can use Tixel for both active acne and for Tixel scars. The protocol is slightly different. This patient was infused with tranexamic acid and retinoic acid. And that's another thing I haven't mentioned is often we infuse retinol. So just in summary, Tixel is a multifunctional technology. It can be ablative, it can be non-ablative, which is great because then your therapist can use it on the non-ablative settings, and you as a doctor can use it on ablative settings. It can be used obviously for skin rejuvenation, and that's the most popular use of Tixel. If it can help for a scar, imagine how it's going to help for perioral lines, or for crow's feet, or for crepey necks, or for hands. So it's a really wonderful skin rejuvenation treatment. But again, I use my Tixel for many different things, and dry eye disease is one of the top. It works brilliantly for dry eye disease, restoring meibomian gland function. That's a talk of its own. Tixel we use for treating acne and for treating acne scars. It's actually useful for treating rosacea, believe it or not. You would think that a thermal treatment on rosacea might be problematic, but it's not, because it is a collagen induction therapy. So when you firm up the epidermis and the dermis, then the vessels are restored to where they're supposed to be, which is in the subcutaneous tissues. And it also helps to normalize the microvasculature in a similar way to microneedling does. It normalizes the microvasculature of the skin. And yeah, so it's a really effective treatment for rosacea. We also use TMA for actinic keratosis, and there's actually a study out, which you can also ask Joe for. But what you do is you apply Effudix cream, the cream, just straight onto the skin after Tixel. And you do it once a month for 3 sessions, and it usually gets rid of early actinic keratosis. It's very good for pores, and it's very good for melasma. So it's a lovely treatment, especially with melasma. You can infuse tranexamic acid and retinoic acid. So my last slide is that the skin permeability of hydrophilic molecules is significantly enhanced by TMA, making it an ideal mode of transdermal drug delivery in patients with keloids, hypertrophic, and burn scars. The low pain associated with TMA makes it suitable for sensitive adult and pediatric scar patients, and it's a promising, versatile fractional system for both ablative and non-ablative skin resurfacing and transdermal drug delivery. And with that, I'd like to say thank you to Tixel for being a very, very valuable tool in my aesthetics journey. Thank you very much.
Thank you, Debbie. That was wonderful. You know, I think that everybody laughs at me because I always say, if you can reach it with a Tixel handpiece, you can treat it. It's literally the way that I've kind of run the Tixels in my practice and with the doctors that have bought it, because it just has so many applications. But yeah, you know, it's a wonderful device for so many different things. So I think what we can do now is we can go on to some Q&As. And let's see what questions we have.
Delia has her hand up.
Delia?
Hi, Joanne. Hi, Debbie.
Hi.
Thank you so much, Debbie. There was an amazing presentation. I've learned so much. Okay, so unfortunately, sorry, this is not to do with the scalp treatment. This is more to do about dry eye diseases or the dry eye of dry eyes. I've got a 17-year-old patient, and he's an avid rugby player, but he suffers with severe dry eyes. That's so much so he has to go for expression of the meibomian glands. So I was just wondering, so if you do Tixel, do you have to, or what do you tell the patient afterwards? If they want to do meibomian expression, or do they leave it, or do they continue?
Jo, do you want me to answer or will you answer?
You're more than welcome to answer if you'd like to.
You can chip in. Delia, you know what? He probably won't need to go for meibomian gland expression after doing Tixel. I would suggest that he starts with at least three sessions, and they're 2 weeks apart. Make sure that the Tixel is done at the correct settings for dry eye disease, and thereafter he could maintain a monthly or every 2-3 months, depending on if it comes back. But yeah, it's no problem if he still needs to do meibomian gland expression, but the whole point is that he shouldn't actually need to do that after Tixel if the Tixel is effective, and it usually is.
Yeah, we've actually found that some patients that have had quite severe blockages in the glands actually self-expressed that evening after they've gone home. So, you know, we've had really, really good results with that, because it is a difficult sort of disease to have. When they have to go for the treatments, you normally have a steaming, then you have a lid scrub, then you have to do the expression, and it's sometimes very, very painful for the patient. So this has been a very, very nice option.
Okay, awesome. Thank you.
Then Nadia has said, please could you elaborate on the mixture of the botulinum toxin 5-FU and the TAC for scars?
Okay. Hi, Nadia. So I didn't mix them all together. I have a pre-mixed bottle of the 5-FU and the triamcinolone. I use an amber glass bottle, and I mix up the 5-FU and the TAC in a ratio of 1:9. I also add a little bit of lignocaine to that as well. So because if I'm going to be injecting keloids, it's jolly sore. So there's always a little bit of lignocaine in there. So I just used like probably about 0.2 mils of that on the patient's scar. And then I just took my normal Botox needle, drew up 5 units of Botox and rubbed that in. It's as simple as that. Okay.
And then Robin has asked, she would like to know more about the amount of passes versus the fluence of the machine on certain conditions. Yeah,
that's a good question about passes. You can do 1 pass, 2 passes, 3 passes with Tixel, depending on results. I mean, Harry Ono, he's our guru. he always does like a minimum of 3 passes, I think, hey, Joe?
Yes, he's a bit scary sometimes. He adds all kinds of stuff on top, but the results are brilliant. So absolutely, you know what, you can have comparative results to CO2, but with really half the downtime, in fact, sometimes 3 times less downtime, and it's really it's not painful like it is with the CO2. So it's really a huge game changer, in my opinion.
But how we decide on how many passes to do, Robin, is really depending on the patient. So what are you treating? What area of the face? Top lip, I'll always do 2 passes because it's a stubborn area, and sometimes I do a third. And with scars, I tend to do 3 passes because you really want results. But if I'm treating dry eyes, 1 pass, you know, so it depends on what you're treating. If I'm treating the skin under the eyes on the lower lid, it's so thin. And it's the first time that you're treating that patient, I'd probably do 1 pass. And then the second time I treat the patient, I might do 2 passes. So it's very much depends on the patient's skin and the area.
Absolutely. And in between your passes, if you've done 1 or 2 passes, you can actually use maybe a little bit of hypochlorous on a piece of gauze, rub the skin nicely, try and actually get all of that dead skin off, and then do another pass as well. So that, you know, that would come. I always like to, once you've bought the machine and if you used it for a little while, then we start going to more advanced treatments when you're a little bit more comfortable with the device. Send that through to you.
I do think that it's very important that whatever you put on after Tixel needs to be sterile. So it needs to come in a glass vial. It needs to be something like this.
Absolutely.
You can't just use a serum that you got off the shelf.
Yeah.
It must be medical grade. It must be designed for mesotherapy because this is a form of mesotherapy.
Absolutely. Robin has asked if you could use intravenous drugs for topical application.
Yeah, you can. So some of them are. Yeah, you can. You can. Just depends what you're treating. Because it's also totally sterile.
Yes. Yes.
About scars, keloid scarring on dark patients. We've had a patient that we've treated with cryotherapy and cortisone for a facial keloid scar, a dark skin patient. And after the treatment that doctor has done, the keloid had gone down and it was better. And then we actually just wanted to treat the residual scarring that was left. And we did it on a very low fluence as well. I think it was 600 that we usually start dark patients on. And I only did 1 pass, and after the second or third treatment, it was like the treatment had activated the keloid again. I'm not sure if that was it, but the keloid had started itching again. It started raising borders again. So we started treating it with cortisone again. Was that the Tixel? Was it because of something else? How do we avoid that?
I don't think it's the Tixel because that's not something that I've seen. But what I do think is this patient wasn't treated with 5-fluorouracil. So a keloid is an abnormality of fibroblast cells. So the fibroblast cells almost act like they're a tumor. They just can't stop dividing, and they just keep on making more and more collagen. So you need to actually use a chemo drug to actually get those fibroblast cells to calm down. So if the scar was itchy after the Tixel, it's actually because the fibroblast cells are still active. That itchiness is because the fibroblasts are so active. So I think that the maybe what could have been done better is to have given cortisone as well as 5-FU, so that you could actually get those fibroblast cells totally sedated. It's like they've got serious ADD, and you need to just get them calmed down. And then I mean, obviously it's possible it was the Tixel that caused that, but it sounds to me more like the actual keloid re-exerting itself, which they do.
Awesome. Thank you, Debbie. Has anybody got any last minute questions before we close? No? Okay, lovely. Well, I hope you all have a wonderful evening. Thank you, Debbie. It's been so enlightening, and we will definitely have some more on different treatment modalities.
Yes, lovely. Okay, good night, everybody.